Good morning, everyone, and welcome to this session, which is zoning in on the concept of evidence-based metabolic bariatric surgery. And I guess on behalf of myself, Wendy Brown, I'm a surgeon here in Melbourne, and my co-moderators, Scott Shikora, that will be known well to you all, and hopefully he'll be joining us soon, and Ronald, Liem, a surgeon from the Netherlands. We were keen to sort of pose this question: does it exist in metabolic bariatric surgery, and is it actually an impossible dream? So to try to answer that question, we've put together a really amazing group of speakers that come to us from around the world, and each one of them is going to sort of tackle a component of this. Each talk is about 15 minutes, and then we have sort of discussion time at the end where we can have a panel discussion and throw to the audience. So think of your best questions and keep them for the end. So we'll start by introducing our first speaker, who's Maurizio De Luca. Maurizio will be well known to you as Mr. Evidence from IFSO family. Maurizio's led a lot of our position statements, and he drives a lot of the research we do in terms of systematic reviews and meta-analyses. So it's a real privilege to have you here, Maurizio, and we look forward to your presentation. Thank you.
Thank you for the kind invitation, and particularly for this item. As I told you, Wendy, I had some presentation in IFSO Congress, but this is one of the presentations where I studied more, and I'm happy about it. I hope to give you an answer. First of all, I have no potential conflict of interest to report for this presentation. This is my first slide, one of the most important of this presentation, regarding on the left side the pyramids of the level of evidence, where I want to point out that at the basis of these pyramids there is the expert opinion, but there is also the conference of expert opinion, the consensus of experts at the basis of the pyramids, while, as you can see, at the top of the pyramids we have the clinical practice guidelines through meta-analysis and through systematic review, with different methods of development of this. One of the best, as you know, is the GRADE. But on the right side of this slide we have also the appraisal and evaluation of the guideline. There are different systems. One of the more adopted is the Agree 2. We are going to talk about it. But I want to underline that one of the domain talks about the explicit link between the recommendation and the supporting evidence. So we know that systematic review and meta-analysis are epidemiological types of study. We do not provide new data, but have great importance for guideline. They allow to have a summary picture of the scientific evidence present on a particular topic. Specifically, systematic review tends to summarize, to collect the result of all available medical studies, while meta-analysis try to analyze and compare results from several similar studies. It's also related to the collection of different studies, but a rigorous meta-analysis is a great approach to give an evidence-based medicine. We need guidelines in our clinical practice regarding the preoperative stages, perioperative stages, postoperative stages. So this is a very interesting document by Lee, who evaluates the assessment of guidelines for bariatric and metabolic surgery through a systematic review of different guidelines, considering the Agree 2, the appraisal of guideline for research and evaluation 2, the most used system of evaluation of guidelines that you can see developed in the right side of our presentation. Considering Agree 2, we know that it consists of 23 items across 6 domains. In the reality, the domains are 8, because there is also a domain regarding the overall quality of guidelines and the potential recommendation for use of the guidelines. We can have through a Likert scale the strong disagreement, through the strong agreement. And after the evaluation of this parameter, gives us the possibility to evaluate the overall assessment score, that if it's more than 70%, we have a document of high quality, a guideline of high quality. So in this study, they analyzed different kinds of guidelines from ISMBS, from IFSO, from EASO, from EIS. And they evaluated the parameter of quality 23 for every guidelines. As you can see, one of the best is the EIS for several reasons. First of all, because it's a great methodology to evaluate the literature, but also other parameters. Reaching the AS guideline, an overall score of 94%. But as you can see, there are different parameters to evaluate that in different domains. In each of one, there are different parameters. And in this presentation, you can see that you have the rigor of development, but also the acceptability. So it's important that at the end of our okay, I have not the possibility to show directly. At the basis of this table, you can see that there is the value of 94 because it's related to not only to the severity of method of evaluation of the literature, but also to the possibility they have a clinical applicability. This is another study, another guideline which is out from this considered before, who consider 22 people with great methodology in order to evaluate the literature, but does consider the agree-to system of evaluation, but another system of evaluation a little bit less complex, and this does has the possibility to compare if these guidelines could have an high quality. So the suggestion is that to use the agree methodology in order to define the quality of some documents, because of it gives more homogeneity, also if it is more technical difficult. Again, this is another interesting study who evaluates 9 surgical guidelines, 5 articles with agree to score more than 60. Usually, the rigor of development is low with an average score of 15.8. We know that agree consider high quality a score of more than 70. But it's interesting because these evaluate also some specific item and not only evaluate the guidelines, but specific item. And considering the rigor of development and the applicability, you can see that there is an item regarding the class 1 obesity that has a good recommendation, and it is usual. The nutritional pre-evaluation, which has a good quality of literature and high grade of recommendation, but strangely we have a grade R regarding also the results of OAGB in the low-term follow-up better than Roux-en-Y gastric bypass. So go ahead with another guidelines, 2024, between the American Society for Gastrointestinal Endoscopy Society of Gastrointestinal Endoscopy. It consists of 14 speakers with great methodology and not any system of evaluation. in this because they analyze also temporary procedure like intragastric balloon. And as you can see, there are, for patients with overweight, only observational studies. When you have only observational studies, you cannot express any recommendation with grade system, because grade system wants that you express recommendation only if you have RCT studies and for interventional treatment. So if we consider a treatment like drug, like endoscopy, like surgery, interventional treatment, we can express a recommendation only through RCT studies. And then we have to see the quality of them. But if you talk about an item, for example, nutritional assessment, also if you have observational studies, you can express a recommendation because it is not considered interventional treatment. Regarding class 1 and 2 obesity, the situation is better. We have RCT studies, some of them of low quality. You know that the platform grade is a platform which considers the quality of the studies. What does it mean? It means that if you have errors and RCT studies, you think that that one is the best studies, but it couldn't be, because if you have a dishomogeneity, for example, age from 17 to 65, BMI from 26 to 65, you have a dishomogeneity of your group, and in that case, the platform grade says you that that paper, that document is of low quality. Then go ahead, consider a patient with class 3 obesity. In this case, we have, in the majority of cases, observational studies, and only in some cases you have RCT studies. So at the end, in the expression of their recommendation, they can say that the indication to endoscopic bariatric treatment for overweight has not a good indication. They write very low indication. In the reality, if you adopt the grade system, you should say we cannot recommend, we cannot express regarding this item, but they say very low expression. No problems regarding patient with class 1 and class 2 obesity, and some RCT with low recommendation for patient with class 3 obesity. What about Italy? Italy is a strange nation because on this item we are very strict. The National Institute of Health in 2017 said that it's mandatory to perform guidelines only through grade system and not in another manner, and sharing every item with all the other society who could have an interest in that item. So we cannot perform any item if we don't share it, the PICO, with the other society. So we developed 3 guidelines, 2 of them by the Italian Society of Bariatric Surgeons and 1 of them from the endocrinologists. Regarding the guidelines of the Italian Society of Bariatric Surgery, we developed the grade system with the ACRI-2, which is mandatory, with 32 PICOs and 2-step Delphi methods. And now we are completing our guideline regarding the endoscopic bariatric surgery, differentiated in 4 domains: indication for endobariatric surgery, temporary gastric procedure, intragastric balloon, revisional surgery, endoscopic diagnostic treatment. And in this case, like in US and the European Society, we have some problems because the literature regarding RCT study is very poor, as we said before. So, take-home messages. Guidelines drive our practice, are recommendations from meta-analysis and systematic review. The best considered guideline evaluation system is the AGREE-2. In guideline development, consider rigor of development, but also applicability. Evaluate the pragmatical, viable, and not only the methodological aspect. In order to answer the question of Wendy, we can say that in MBS there are few guidelines with an overall assessment score more than 70 and can be considered high quality. I wait for you next year for IFSO EC Congress in a very nice and historical and cultural city, which is Venice, with a very good and innovative program. Thank you for your attention.
Thank you very much, Mauricio, and giving this in-depth insight in the available evidence for metabolic and bariatric surgery. We will do all the questions in the discussion afterwards.
Okay.
Yes?
Thank you.
As Phil Schauer has not arrived yet to this room, I want to introduce the next speaker, and it is my pleasure and privilege to introduce Jamie Art. He is the current president of the Obesity Society and also professor in the Department of Epidemiology and Prevention in the Division of Public Health Sciences at the Wake Forest University in the United States.
Good morning. It's my pleasure to be here, and I appreciate the opportunity to have a chance to talk about this topic of emerging medical therapies. How will they change metabolic bariatric surgery practice, and do we need more evidence? So just as context, I'm a clinician, internal medicine background. I co-direct our weight management center, and we have a comprehensive center where we have medical and surgical therapies provided for our patients. And this is a question that we've begun to grapple with even more, especially in the sort of era of what we're calling sort of third generation anti-obesity medications. I'm going to mostly focus on that as the point of discussion. Won't get into endobariatrics as much because I think most acutely, I think the main question for a lot of people in their day-to-day practice is how do we deal with anti-obesity medications that are now starting to get double-digit weight reduction on average across a broader population of people with less intensive behavioral therapy required to get that level of effectiveness. So let's get started. Here are my disclosures. And here are the objectives that Wendy asked me to speak to. Will anti-obesity medication replace metabolic and bariatric surgery? Will AOMs be synergistic with metabolic and bariatric surgery? And what evidence is needed to support combination therapy? So first question, will AOMs replace metabolic and bariatric surgery? Here's some considerations that I went through when thinking about that question. So first off is we know that the proportion of people with BMIs greater than 40 is increasing. And this is just showing regional trends in severe obesity or in obesity generally. But when you start to look at places like the U.S., this trend is shown here with the green line showing severe obesity. We're seeing that that category of obesity is increasing so that once people hit sort of a threshold, we start to see that there's a progressive nature to the weight gain that people are experiencing, especially if they're hitting higher BMIs earlier in life through mid-adulthood. So we also know that the tolerability and heterogeneity of treatment response to a given anti-obesity medication is something of a mystery in terms of predicting that response, and we know that not everyone can tolerate these medications or gets the average treatment response. The other issue I think that's important in terms of addressing this question about will AOMs replace metabolic bariatric surgery is that we know that the indication for metabolic and bariatric surgery is now lower. So BMI in the 30 to 35 or 34.9 range with complications or 35 and higher. So now you're starting to see a similar indication sort of strata for metabolic bariatric surgery compared to anti-obesity medications. Clearly not exactly the same, but certainly some overlap. And then the other consideration, I think, is in the social cultural space. So in the US, for example, where we have a lot of employer-based insurance, a lot of insurers or employers are starting to limit their coverage of anti-obesity medication. Here are two examples. The Mayo Clinic has now, as a health system, right? This is not just a random, sort of blue-collar labor type of union, or this is a healthcare system that has decided to limit use of anti-obesity medications for employees by putting a cap, essentially, on lifetime usage. This has also happened at University of Michigan, and you can see it's grouped in the same type of category as infertility treatments, right? So again, we still have a bias that suggests that these treatments are elective, they're not really necessary, they're for short-term use, limited use. People theoretically should get treatment and then learn their way out of the disease, is how we tend to think about that, right? And so there is going to be an ongoing discussion, especially as cost remains high, about access and coverage. And then there's also the issue of acceptance of long-term therapy. Patients themselves often don't want to be on long-term medication treatment. One of the first questions patients ask me when I talk about anti-obesity medication therapy is, well, how long do I have to be on this? And that is not a question we get when we talk about lipid management, blood glucose control, hypertension, any other chronic disease. Other things that we're seeing in our own data, and you may be seeing this in your center, is that sleeve gastrectomy is decreasing. So we've seen about a 10% decrease in the proportion of cases that are sleeves, and those are shifting over into more malabsorptive procedures like Roux-en-Y or SADIs. And we're also seeing that some of that is just a result of people are seeing, average weight response with some of our best AOMs now is starting to compete or overlap with what we might see in terms of average weight response with sleeve gastrectomy. And clearly people have become interested in AOMs because of the social media presence and just general media discussion. In the OBSERVE study, which was conducted in the US, we asked over 1,000 people, what's the magnitude of weight loss that you'd be happy with? And you're starting to see now that people's dream weight loss response is about 24% of their initial body weight on average. And they would be happy with about 15% weight reduction. So now this is in the category, this is within reach of the newest AOMs. And with older AOMs, we can certainly get there with the right type of treatment strategy. And you can see here that most people are going to be happy with double-digit % weight reduction, which is prior to first and second generation, or prior to third generation AOMs like the GLP-1 based treatments. We weren't seeing that on average. You could get that in maybe specialty settings with, again, more intensive lifestyle intervention combined or combination therapies. But now we're seeing, yes, this is much more reasonable as an expectation. And this is what people are looking for in terms of therapy. So we are starting to see that impact. So I think in total, will AOMs replace metabolic bariatric surgery? I would say the answer is no. I think the headwinds are suggesting that, yes, AOMs will be competitive with some aspects of metabolic and bariatric surgery, but on average, there's still considerations about disease severity, the desired treatment effect, and constraints about AOM access, along with thinking about the heterogeneity of treatment response. And we haven't even talked about the idea that we think about all obesity being the same when we know that there are a variety of different types of obesity, ranging from medication-induced to hypothalamic obesity to other factors that are really driven by social determinants of health and the response to the obesogenic environment. So all of those things are very different, and I think it's really sort of a false flag for us to say, okay, yeah, we see this as a threat to metabolic and bariatric surgery, when I think where we ultimately would go is say, this is going to be complementary and expand our range of treatment options so we can get better treatment outcomes across the board. So that leads to this next question about synergy with metabolic and bariatric surgery. And I think the data here are scant, but I think there's some signals that tell us we should keep going in this direction. So here's one framework that's being presented by shared colleagues that uses the phrasing neoadjuvant to describe using anti-obesity medication before surgery, sort of in preparation, if you will. And the intent might be, say, reduce liver size or improve the technical ease of surgery, or even ideally extend the amount of weight loss, the total weight loss that's achieved throughout the treatment course. There aren't a lot of studies that are purely looking at neoadjuvant use, but there's one small case report here, a series that's basically looking at use of phentermine plus or minus topiramate in patients with BMI of 60, small sample, 1 year post-op. You see about an 11% difference in the neoadjuvant use compared to no neoadjuvant use. In terms of adjuvant use, so this is after bariatric surgery, so you say have the patient have their surgery of choice, and then we're going to decide at some point post-operatively to initiate anti-obesity medication. And that could be for an indication of, say, lower than expected weight loss trajectory or additional health benefit. So in this particular case, there are 2 studies that are randomized controlled trials that help inform some of the idea that, yes, this is feasible. The Gravitas study by Alex Miras and team, they looked at liraglutide 1.8 milligrams as an indication for treating people who did not have resolution of type 2 diabetes, so they had an A1C greater than 6.5 1 year post-op. And you can see here that they had reductions in A1C at the top, and then also reduction in body weight from that baseline randomization. We also have the Berry optimized study that looked at liraglutide 3 milligrams, so this is the indicated dose for weight reduction, and used that in patients who had a less than ideal treatment response at 1 year in terms of weight. And so that was 20% weight loss was the cut point. And you can see here, using liraglutide 3 milligrams, you see a nice weight reduction that is on average slightly better than what we would expect with liraglutide 3 milligrams, which is usually about 6% weight reduction. So the other question is, what about combining neoadjuvant and adjuvant? So starting anti-obesity medication before surgery and then continuing it after surgery. There aren't a lot of studies, again, in this space. We have one of the only studies where we looked at in patients with BMIs greater than 50 using phentermine topiramate extended release pre-surgery and then continuing it after a sleeve gastrectomy 1 month after surgery. And what we saw is that in the initial run-up to surgery with the drug-treated group, you saw a reduction of body weight that was about double what our standard of care was. And then, so they've already made up the stagger in terms of the difference in baseline BMI. And then when you look at the weight loss over the course of time, you see a separation in the curve starting within the first 4 months and extending out through 25 months. And that average difference after surgery is an additional 11%. So there's some suggestion that there can be synergy with anti-obesity medication and metabolic bariatric surgery. I think one of the areas that's most exciting in my mind is what's happening in the development space around medications that will target lean mass augmentation. So you have, bimagrumab, trevogrumab, and garadacimab, which are anti-myostatin or activin A treatments that will preferentially increase lean mass. And that could be very synergistic when we think about some of the challenges that we see with lean mass loss with metabolic and bariatric surgery. So why don't we already know these answers? I think partly it's we just need better systems of care. We need to think about a continuum of care rather than these categorical, you failed or you succeeded with a treatment. Treating to target is one of those things that I think could help drive our collective way of thinking rather than just sort of getting some average treatment response. I think the other thing that can be helpful is if we start to conceptualize the effectiveness of a given strategy is really based on having a degree and duration of negative energy balance that is sustained and sufficient to lead to weight reduction, but we also have a measure that mitigates the metabolic adaptation that occurs to slow down weight reduction. So a classical calorie restriction short-term intervention might lead to significant negative energy balance and weight loss, but then you have a rebound metabolic adaptation that often is, followed by weight regain. A short-term weight loss, like using a first or second generation AOM, might give you some small weight reduction because you can sustain negative energy balance for a while, but you don't see the same degree or extent that we're seeing with current generations. And this is what metabolic or bariatric surgery or our newest generations of AOMs might do. So as I start to finish up here in terms of thinking about what we need to get to the next level, I think starting to conceptualize the idea of synergy based on this concept of driving and sustaining a negative energy balance and having a counteractive force to metabolic adaptation might help us start to get to a point where what we see is that we've got a low degree of metabolic adaptation with a sustained effective duration of negative energy balance that allows us to go beyond where we are currently with either metabolic and bariatric surgery or AOMs alone. So what's the evidence needed to support combination therapy? There are lots of questions still about optimal timing and sequencing of combination therapy. Is synergy a function of when you stage one versus the other? Does the use of AOM first or second make a difference? How do we match these treatments to the patient based on their mechanism of disease or how they are experiencing obesity? And then I think ultimately we need a biomarker that helps us drive to this idea of really sort of treating to an effective energy homeostasis. I think there are a number of randomized controlled trials that we could dream up that look at going from neoadjuvant to adjuvant treatment, low dose therapy in terms of AOMs versus an approved dose, maybe even new indications for weight maintenance, continuous versus intermittent use of metabolic and bariatric surgery as a post-AOM treatment and maintenance. So discontinuing AOM treatment, but using metabolic and bariatric surgery as a part of a long-term maintenance strategy, and then early versus late use of an AOM. All of those things are really important. I think we also need to understand who might benefit most from this approach. And that's accomplished through prospective phenotyping, both in terms of things that are clinically feasible and doable, in a short order versus really deep discovery and deep phenotyping. And then also doing retrospective assessments and registries to be able to use AI and machine learning. Thank you for your time.
It's a pleasure for me to introduce the next speaker. It's Professor Amir Ghaffari, who's a professor of surgery at the Medical College of Wisconsin in the United States, President and CEO of the Physician Enterprise, Senior Associate Dean for Clinical Affairs. And he's going to speak on beyond the RCT. Are there pragmatic ways we can collect high-quality data to improve metabolic bariatric surgery practice?
Great, thank you so much, Scott, and thank you, Wendy, Ronald, and Scott for the invitation to speak. That was an awesome talk. I feel like you answered a lot of questions I have, but then raised 50 more that we need to be thinking about, so I appreciate that. I was given the dubious task of trying to come up with a way to talk about how we can go beyond the RCT, and so I'll go into the disclosures. Again, I've received funding for some of the work that I'm going to discuss, and have received federal agency funding. So these are the two objectives that Wendy gave me, which was discuss the role of registries in answering the question of moving beyond RCTs, as well as discuss the ideal pathway for new procedure development. So I have a lot of expertise in the first one and pretty much zero in the second one. So I'm going to focus mostly on the first one, and I know a guy who knows a guy who knows a gal about the ideal pathway. So I'll point you in that direction toward the end of the talk. So many of you, hopefully everybody in this room is familiar with the IFSO Global Registry Report. So we just published the 8th report. If you're not, I'd encourage you to just do a quick Google IFSO Global Registry Report, and you can download it as a PDF. This is led through the efforts of Wendy and Ronald, really leading a team around the world to put together a registry report that has evolved over time since the first one that was created. And this is a purpose statement that's within the document of the IFSO Global Registry Report. But I think one of the most important pieces here is to create a credible and transparent information. To create the most credible and transparent information. That's the purpose of a registry. But what I'm going to talk about is moving beyond that and how we can begin to think about practice change using the power of data within a registry, whether that's local, regional, national, or international. So this is the only data slide from that report. Again, I'd encourage you to download it. I think it's like page 8 or 9, has a beautiful one-page summary of the findings within the registry report. But we're very proud to say about 24 national and regional registries were included, totaling almost 500,000 procedures around the world that were included here. I think it's you can imagine the power of the numbers here. Many of our countries individually, may contribute 6, 10, 15,000 cases, but you pull that together and you have a lot of potential power there. So the question I was again posed was, how do we use registries to move beyond the RCT to develop evidence that can drive our practice? And so one of the things I'd say for those of you in the audience who are not participating in registries, national or regional registries, you can build your own as well. I think it's valuable building institutional or multi-institutional registries, and I think this is an outstanding article that highlights kind of the successful features of a surgical registry, and these are essentially the 9 elements that they highlight in the paper. Very, very well done, and again, I would encourage you not to be overwhelmed by this, but to chip away at it and develop a registry that you can begin to monitor your own surgical procedures and care. So again, like I said, I'm an expert in the first one, I would say, around registry. So I'm going to talk a little bit about my experience in the United States, in the state of Michigan, where we have a statewide clinical registry that captures nearly 100% of all bariatric surgical procedures. And I'll highlight 2 areas where we've made significant impact in evaluating not only what happens in the operating room, but also what happens prior to the operating room. So what we do to our patients leading up to surgery, and some really impactful change that came about simply because we had the registry and we had the people submitting data and reviewing that data. So the MBSC now it's in its 19th year of existence. We are funded by Blue Cross Blue Shield of Michigan, which is an insurer in the state of Michigan, but we capture patients who come from all insurance types. The process is very simple. People submit data, and these are abstracted at the local sites. There is central analysis of the data that happens every night. It's automatic. It's a online portal that there's nightly risk and reliability adjustment of the data, and you can look at your data live the next morning based off of what's been submitted. But then we also have to design strategies, and so we get together and look at the data and then design strategies on what we want to improve and identify areas that we want to improve. And oftentimes identify areas that we're not collecting data and immediately adding those data fields to our registry and beginning to look forward. And we've done that recently. We're starting to do that with AOMs because I think that is kind of the Wild West, and we have the opportunity to begin collecting some data. Again, it's not prospective, but we would have a better understanding of what our patients are receiving at the time of surgery. But other things like balloons or endoscopic treatments, we've begun to collect data around those to get a sense of what's happening within our environment. So this is our mission statement, and I think the reason I put this up is it's important that we're looking to advance the science and practice of bariatric surgery. This isn't about comparing our outcomes with one another. It really is about moving the field forward. And I think that's a really important principle that we have within the registry, and one that, if you go back to that BMJ Open paper, is something you want to establish early on. The point of registries is not for competition. It's not to compare yourself, but it is truly about a process improvement and quality improvement protocol. So here are 2 registry-driven assessments that really improved the level and quality of care, at least in the state of Michigan, and I know beyond that as some of this work was disseminated. One is around technical skill in the operating room, and this is an example you can think about as we have more and more procedures or different types of procedures, novel procedures, augmentation of existing procedures that occur, evaluating the skill and what that looks like in the operating room can be very valuable. And the second was around inferior vena cava filter use, which I'm sure many people don't use anymore, but I'll show you as an example of where we use the power of the registry to demonstrate to our participants and our contributors where there might be some opportunity to improve the safety of care. Again, that's around the practice, right? And so we think about the previous talk around AOMs. You can glean quite a bit of information from a registry like this as you begin to capture more and more data from larger and larger volumes of patients. So technical skill is an area where I'd say it espouses the core values of surgery, and surgeons also love to watch videos of each other operating. We just love videos. I heard there was maybe some videos this morning, and in all these sessions, I think it's nice to have. But it also requires trust and some reliability of the data that's being submitted or reviewed, and then true collaboration. And so for some of the surgeons in the room, you're probably aware of many of the Facebook groups that now exist, where people submit cases and ask for critiques from colleagues of challenging cases and even routine cases. So it's become much more norm to watch each other operate. And because we do laparoscopy, it's much easier to record and observe each other. And this is the story of how we applied that within the registry and our membership. So, some refer to the OR as the black box of surgery. Nobody kind of knows what happens. Patient goes in, comes out. We all do things slightly differently, even though everyone says I create a 32 French sleeve, and I've seen a 32 French sleeve that looks more like a 60, and a 32 French, so we all know we do it slightly different. And our operative notes and operative dictations don't always capture that. But video doesn't lie. The video is exactly what happened in the operating room, and we can record that and observe that and actually evaluate each other. And so what we did in this study several years ago was we took evaluations of videos in the operating room, had surgeons actually evaluate and score each other, all blinded, and then we were able to link the scores for those operations to clinical outcomes for those individual surgeons. And here's what we found. Now you see the blue is the bottom quartile of surgical skill as assessed by their peers. And the yellow is the highest quartile, the highest skill level, again, assessed by a group of your peers. And you'll see a very linear, stepwise reduction in all complications, both surgical and medical, as your skill level improves. This was pretty remarkable to see. It's something we all intuitively knew, but to think that what we're doing in the operating room, small tweaks in the operating room that are visible by our colleagues could actually impact the patient's perioperative or 30-day outcomes. And so we took that one step further and said, we need to open this up to everybody in the collaborative. And we had the great clinical registry data. And again, we ask ourselves a lot of times as we're evolving new operations and new procedures, we need more data. Well, we are continuing to collect that behind the scenes, right? One of the things you'll see in the IFSO registry report is that there's a growing category of other for procedures. I think other, it's hard to know what that is, but it could be procedures we're making up because of the anatomy that's before us, or it could be procedures that are kind of on the cutting edge, and we need to start to begin to understand what those look like. So we had people submit their videos. Again, they underwent review. But what we did is we then said, well, let's try to improve. And so we created a coaching program that was having peer-to-peer coaching, reviewing the videos. We paired high-skilled, again, as rated by their peers, to low-skilled surgeons and paired them up and had them kind of watch videos together. And this is what a live coaching session looked like. And we were doing this every 3 months as part of our collaborative meetings. We would have 2 surgeons paired up, and they would critique the other in front of a group. And everybody was learning. And then you broke off into smaller, just one-on-one groups. But this led to a significant amount of improvement for many of our surgeons. It may not have been demonstrable outcomes, such as complications, but certainly speed of operation, length of stay, things of that sort that really did improve as a result of this. And again, this has become more mainstream now with the use of social media and specifically the Facebook groups. I think there's a large cadre of them that are through SAGES that are available, but then there's obviously other independent ones as well. So that was the power of the registry in evaluating a new, existing procedures, but a way we can apply that to new upcoming procedures or procedures that are gaining ground and volume. So the second thing I'll talk about is IVC filter utilization. And so I'm sure many are familiar with the Greenfield filter or IVC filter. And so this was being used quite a bit. And I'll say this is an example where there was a little bit of a gestalt that these are maybe not super necessary, but nobody really had the right data to look at this. And it's also an example of how you can create very rapid practice change amongst a large heterogeneous group of surgeons and practices in a pretty short amount of time when you have very strong, reliable data, which was really the purpose of this. And so I'll give a brief background on this. So in the state of Michigan at the time, we had 20 hospitals or programs that were submitting data. This was early in our collaborative. And you'll see there that there was about 10% of patients overall were receiving prophylactic, so preoperative IVC filters to reduce the risk of venous thromboembolism. But that wasn't where the story was interesting. It was interesting in that when you looked by site, there were sites that were putting in 0 filters and sites that were putting them in up to a third of their patients. So when you see variation like that, you know the answer, no one's right, no one's wrong. There's some nuance here that we need to understand. In this case, there might have been a right and a wrong, but oftentimes the truth is somewhere in the middle. And so what we did was then, because of the reliable, trusted data we had that people were submitting to the registry, we then evaluated the clinical outcomes in those patients and in those programs who were having filters, who had filters placed versus those who didn't. And again, to summarize that here, it's pretty straightforward. Patients who were having prophylactic filters put in had a higher risk of mortality, complications, et cetera. So some might say, the epidemiologist in the room might say, well, that's just, there's an association with a sicker patient, you're going to put a filter in, of course. You can't measure that in this propensity matched or matched controls. I know all the stuff that epidemiologists are going to point fingers at. So what can you do in a registry? Well, you can actually go and you have the data, you have the people, you go do some reviews of those events. And what we found was the preponderance of events and complications were actually filter related. So it wasn't something going on with the operation. It wasn't because the patient was sicker. It was a complication of the actual filter that was in that led to either morbidity or mortality. And so what we did in the collaborative, we obviously published it because it's always good to publish your work, but we shared that data in a room just like this with no judgment, just saying, look, this is what we found. What do you think? There was a lot of discussion, and the intervention there really is just displaying the data. But the discussion happened amongst peers. And again, this is the power of a registry, the power of data. The group kind of organically began to reduce their use of IVC filters. There was no need for an external body or someone to say you can't do this anymore. But you'll see over the course of about 2 years, we went down to almost 0% of patients having IVC filters placed. And again, this has bled over, no pun intended, bled over into national standards, international standards. I don't think anybody really uses them anymore, except for very, very, very select cases. So again, another example of how a registry can influence and evaluate clinical practice as we know it. So I've got 30 seconds, which is perfect for the ideal part since I know nothing about it. But I will say, I know Peter McCullough pretty well at Oxford, who helped create this. And here's a little bit about what the ideal framework is. I put the website there because you can go on there. There's a beautiful toolkit and everything that you can evaluate on there, and I'm sure Peter would love to talk to you about it as well. But essentially, it's the idea of having a systematic way of evaluating new procedures, new technology. Again, they talk about devices and stuff as well. But it's a framework for how to do that. And you can imagine we have a lot of people creating new or innovative procedures or modifications of existing bariatric procedures. And how great would it be if we could flow through this? Now, Wendy, one of the problems with the ideal framework is it calls for an RCT somewhere in the middle. So I think that's kind of the nuance where we'd have to, again, use registries. Here you see there in the assessment for ideal, and the bottom right there, preferably an RCT. But again, probably not necessary if we use the principles we just applied and discussed around registries and incorporated that into this ideal framework. All right, so my time limit is exceeded, so I'm going to say thank you, and happy to take any questions during the Q&A period. Thanks again.